In this video, I will cover the presentation of a winging scapula. Expect to learn the following: clinical signs of a winging scapula, what causes it, why simply trying to strengthen the serratus anterior is wrong, and how do we properly address it and fix it. For those of you who don't know me, my name is Dr. 𝘚𝘬𝘳𝘐𝐭, and I'm a non-surgical expert in chronic pain treatment. My focus is on finding and fixing nerves that become stuck to muscles with a glue-like substance called adhesion, also known as scar tissue, and reducing inflammation from chronic pain naturally without the use of medications or injections. This results in a significant increase in flexibility, function, and long-lasting pain relief. I'm also the creator of the Peak Method, where we teach overworked massage therapists a new treatment system that cuts session times in half and eliminates the frustration of inconsistent results so they can avoid burnout and help more people get out of pain. All right, let's get right into the video, understanding a winging scapula presentation. Clinical signs, causes, why strengthening is wrong for, and how to fix it. I actually saw a bunch of these in the last couple of weeks in the clinic, so I thought it'd be a good idea to, refresh this and make a video on it. I've talked about it in the past, but it's always a good concept to understand. So let's get into it. So what are some clinical signs of a winging scapula? Basically, what it says in the name: the scapula wings out. A lot of times when I'm assessing a client, when I'm doing a shoulder functional evaluation, I'm really looking at this inferior angle down here of the shoulder blade. And a lot of times when it's kind of, pitched out further to the side there, a lot of times what's going to happen is that's where the winging scapula is happening. But a lot of times when you do like a thorough and in-depth history on the patient as well, you will notice that they've kind of had a history of like shoulder pain, dysfunction, and stuff like that too. A lot of times maybe trouble with like pressing motions, or maybe there are people that sit at a computer or a desk all day long. And over time, that winging scapula starts to happen because it's actually a compensation. So big thing I like to do is I like to look at a test from the posterior, from behind, where we have them bring their arms fully up and see if their biceps can touch their ears without a lot of extra motion in the scapula as well. The winging should not happen. It is definitely a compensation that is going on in that presentation. So what causes it? Really, it goes down to rotator cuff dysfunction. The most common is going to be adhesion buildup in and around the structures of the rotator cuff. I tend to see it first develop in what is called the posterior capsule. So the capsule basically sits on the back part of the shoulder. It's between the tricep and the rear delt. And what happens is the capsule is like a ligament, and it really helps for like force production and things like that. And a lot of times that one just gets overworked, beat up. Capsules don't get as much blood flow and oxygen. So when it does develop that adhesion in the capsule, it makes the structure less flexible and weaker. So then the force has to go somewhere. Then I start to see some adhesion build up in the infraspinatus, the subscapularis, and sometimes in the supraspinatus as well. That's when they start getting a little bit more pain, a little more decreased flexibility, maybe less force production. Then I start to see it build up in the nerves, and they get nerve entrapments, specifically in the suprascapular nerve and the brachial cords and in and around the subscapularis. Now, when the nerve entrapment happens, that's when things start to get a little more troublesome. That's when they're going to get more intense symptoms. They might get some shooting pain, some stabbing pain. You're going to see a lot of these biomechanical distortions at this point as well, because when the nervous system is compromised and entrapped, the body does whatever it can to protect that. And a lot of times you're going to see that compensatory action of a winging scapula to work around the rotator cuff dysfunction, because the body doesn't really care. It goes, hey, we need to generate movement and stability in the shoulder. We're not getting it from these other areas for some reason, because there's adhesion, there's nerve entrapments, things are built up in there. So, hey, serratus, kick on, help us. So a lot of times what I end up saying is the winging scapula is the effect. It's not the true cause. So why trying to fix serratus anterior muscle weakness is wrong? Basically they just go into, they're like, hey, do push-up plus, or do wall angels, something like that, to really isolate the wing scapula, strengthen it. It goes back to the idea I talk all the time. Is it the cause or the effect? And the winging scapula is definitely the effect, but it's not the true cause. It's trying to undermine and underwork those underlying dysfunctions in the rotator cuff. And then you get those biomechanical compensations as well. So a lot of times when the suprascapular nerve, which is really important, gets entrapped, and then the brachial cords as well, it kind of rolls that shoulder forward a little bit to shorten that area, so that if you do use it, you're taking some pressure off of those nerves and they can buy a little bit of time. Hence, the scapula still has to move, so the serratus kicks on to do it. You always want to answer the question too of like, why is something weak? Why is something tight? Why is something weak? The physical therapists go, oh, it's tight, so stretch it. It's weak, so strengthen it. But it's like, yeah, maybe, but like, what's really going on? What are the underlying factors in there? And most of the time, most common cause, most underdiagnosed, and most fixable cause of most of these problems is going to be adhesion and scar tissue buildup in the muscles around the rotator cuff, in the nerves, in the capsule as well. So they don't need more stretching. They don't need more strengthening. They need a manual, hands-on approach to actually fix that problem. So first area that I like to start, and when I'm addressing it, is you need to get rid of the nerve entrapments first. So if you just treat the capsule first, or just the muscle surrounding fascia and everything like that, but you don't treat the nerve entrapment, that problem's going to come right back. The body has like a hierarchy of things that it needs to have treated first. And the first thing is you got to remove that nerve entrapment. Now, I'm not talking about the neuromuscular people that play tricks on the brain and they're like, oh yeah, we can do this. And look, it's magically better in one visit. And then it comes right back. No, you have to actually get in there and physically break down that suprascapular nerve. What I end up finding a lot of times is when providers are treating this area, they're way too compressive in there. And they actually don't account for the 45-degree angle of the infraspinatus and the way the shoulder blade is orientated. So a lot of times they're too compressive and they get too much depth, and then the tissue doesn't slide. So basically what you need to do where the suprascapular entrapment occurs is just below what is called the suprascapular notch. It comes out right through here. And basically you want to get your depth just above it. And then you want to tension into it and then let that tissue slide. So you don't need a lot of force here because it's not very thick there. There's not a lot of deeper tissue. It's really basically like the skin, some subcutaneous fat, and then the infraspinatus. So a lot of times people are way too compressive. If you're getting there with your elbow, you're just being a jackwagon and you're just making it hurt, but you're not actually fixing anything. Nerves are really particular. They're like Goldilocks. They want just the right amount of depth, just the right amount of tension. We teach a lot of this in our free training modules where we go through that and help you understand the concepts of proper depth and tension. So if you haven't checked those out, make sure you download those as well. They're available wherever you're watching any of this video. Next thing we want to look at is the brachial cords at the subscap. So basically on top of the subscapularis is all the brachial cords. You could have the radial nerve, ulnar nerve, median nerve, musculocutaneous nerve, axillary nerve, so many nerves. Obviously I know a little bit about anatomy, but same kind of concept as the back part of the infraspinatus. Subscap is kind of set up the same way. And what I find here is that providers usually aren't actually on it. They're usually down on like the teres major or out on the lats. They're not actually on this area. And if they do get in there, a lot of times they end up being right on top of those brachial cords. Hurts like hell, entraps it, compresses it, doesn't feel great. You think because it hurts, it's doing something. The client thinks because it hurts, it's doing something. It's doing a whole lot of nothing. So you want to get just right in there, nice and easy and nice and free. And when you free up those nerve entrapments, then the shoulder just starts to move better. And then you can start to work the surrounding structures. Then I'll get into what's called the posterior shoulder capsule. Capsule is a little bit different. The key on this one is really slowing down, palpating, and finding it. A lot of times what I end up seeing is that providers are usually too far on the tricep or they're too far back on the rear delt. It's somewhere in the middle. And when you get right on it, capsules are different. A lot of manual therapy, when we get some depth, we back out and then we take some tension. With a capsule, we don't. We get full depth and then we get full tension. And then at the end range of the motion, we hold that for about 8 to 10 seconds because it's a ligament. It needs a more focused, direct type of treatment in there as well. But you don't want to start by treating the capsule. You want to clean all the other stuff up and then get into the capsule. So when should we build the strength back up? There's an order of operations for fixing any problem. The first is we just got to increase all the range of motion. That starts by finding and fixing the adhesion. So treat the nerve entrapments first, then the muscles, then the ligaments. And then once that is really good, we actually want to get into some corrective type of exercise to balance some of the strength in that area. So what I like to do, especially for the shoulder and the rotator cuff, is I do some side lying infraspinatus isolation. Then if that's good, we do go into a overhead press as well, but we want to slowly build that strength back up. And then once things are really good, everything's functioning good, the tests are good, you've cleared up all the adhesion, then we want to increase global strength. And a big exercise I like to do is what I call an overhead carry, where they have a kettlebell or a weight over there, and then they walk around. It really helps to build up the rest of the stability in the shoulder and go from there. But you want to follow the order of operations. Get the range of motion back first, then balance the strength, then increase the strength. PT has it completely backwards. They start to do exercises and stretches right away. That would be like trying to fix a cavity by brushing and flossing. It's not going to work, and that's why they don't get good results. We're manual therapists. We should be the first person that people see because we can get in there with our hands, find and fix and break down that adhesion, that nerve entrapment, and get things functioning and moving a heck of a lot better. Then you can get into the corrective exercise. You can even refer it out to somebody if you don't want to do it in your own office. But our job as manual providers is use our hands, get in there, break it down, and make some big changes in the muscle. All fired up about manual therapy today. That's all I got in the video. Appreciate you watching. Hey, share any insights you might have gotten in the comment section below. I try my best to engage and talk to anyone that has some like legit questions. If you're a PT and you're like, oh, where's your research? I'm not gonna deal with you because you're a moron. Next is you can share this with other providers that you know it might help. Always want to get this care to more people, help more people get out of pain so they can stay the hell away from pain pills, injections, and surgeries. And lastly, if you like what I'm teaching, you like what I'm training, you go download our free training modules. In that training module, we actually do a full shoulder assessment. You're going to see treatment of infraspinatus, treatment of these nerve entrapments, treatment of the capsule as well, palpations, everything like that. So you can really get a better idea of the system and get on the path to actually solving problems and not just providing solutions. I appreciate you checking out the video, and I'll catch you on the next one. Bye.